And we're live. Good morning, gentlemen.
Morning.
Tryptophan. Have you flushed the tryptophan, the secret ingredient in all the turkey, out of your system from Thursday?
So I'll tell you what, I was just telling my PTA, I never have osteoarthritic kind of pain in my knee. And thank you, Thanksgiving. My left medial condyle is killing me. And I've barely been running. Like I run a couple miles and it hurts so bad. I hate it.
From what? From all the...
I think all the crap that I was eating, like I would never eat pecan pie, apple pie, cherry pie. We had 2 Moscow mules. Like I would never do that kind of stuff until this time of year. And now my 49-year-old body is hating me for it.
You might have to drop the meat.
The meat? Heck no. Drop the junk. I do best on like a full keto, paleo diet. I do really well. My body doesn't tolerate vegan at all. I've tried it before.
So favorite food then, what's the junk? What's the opposite of the junk?
What do you mean what's the opposite? Like if I cut out the wheat, I cut out the dairy, I cut out the alcohol, I feel amazing.
Yeah.
There you go. All right, so we're doing predictions, right?
Say that again.
So we're doing predictions?
We are. Prediction episode. Let's go.
All right, so we'll do it round robin style. What's the order you want to go in? Does it matter? Because we don't know what each other's predictions are right now. Rock, paper, scissors.
You lead it.
All right. Well, so we'll each make 2 predictions and we'll make it a 6-pack.
Yeah.
First and foremost, I think in the last 365, we played around with this. This has to be on everyone's list. I'd be dumbfounded if it wasn't, because the first thing I did to prepare for this episode was open up artificial intelligence and say, hey, let's play around with some ideas. And what do you think the prediction in 2025 will be? I started with healthcare, and then it was getting way too broad, which was kind of cool, is it was starting to slide all around and get into some deep crevices. Because I think I said, give me 6 ideas, because I wanted to come with like 3 or 4 in case one of you guys had my ideas. I could pivot and audible really quickly. But first, we'll just start with, I think the use of artificial intelligence, I think healthcare is, I'm trying to think of an industry that's more risk averse. Like we absolutely run away from anything like sort of even mildly risky. Like I watch it on clinicians' faces when they're like, well, like, you know, what is this a little bit? It's like we play the devil. We're like, if there's one opportunity for this thing to be bad, we won't do it. Instead of leaning into it and saying, well, okay, what is it now? And what will it be 3 years from now? So understanding that however you're using it now, the 3-year from you version will just you will be mocked. So I pay attention to the opposite, how I got to this, or I'll be more specific. I won't just say the use of AI. That's too broad. I still think that apps like HippoScribe or products like HippoScribe will be commonplace. I see them when they are discussed in front of students and their eyes light up because they're at the end of a diving board. I was talking to students just a week and a half ago, and they're like, I'm 6 months away from graduating. And I always ask these questions, what are you excited about? And what are you scared about? Excited about the possibilities, and they're scared about seeing 100 patients a week and having to document and being miserable. If this alleviates a thing that you're annoyed with, it will be adopted. It will grow. People will lean into it. Right now, they're not. I think you can double down. If you were going to jump on one of these and lean into it, you have the first mover advantage. It's going to happen. You cannot. I would love to hear an argument for why AI documentation is not going to be widespread in a year and a half, 2 years. I'd love to hear an argument for the opposite, but that's my first prediction, which sounds like the lamest prediction because this feels like it's looming. Thoughts?
I'll give you an argument why it's not, because we are physical therapists and we are scared of our shadows. We are scared of compliance. We are scared of everything that's out there. I totally agree with you. It absolutely should be. It should be commonplace. It should be in everybody's backpack. But I've seen this profession for too long do everything in their power to slow down progress, slow down innovation, and hurt ourselves. So I just think it's going to be because of our own fears and insecurities that it's not going to happen. Dave, what do you think? You're nodding.
One of my predictions is mentioning AI. So I think I want to save that energy and juice for when I'm up.
Yeah.
Well, you're up right now. Let's go.
All right. So I have two predictions. One is more, and one is AI. Which one do you guys want to hear first?
Let's carry the AI
Keep the
flag,
energy.
because I've got an AI one also that I'll just keep changing until to make sure I don't copy you guys.
Okay. So yes, I agree. Things like HippoScribe, dictating a note so that therapists in the future, in the near future, or even now, don't have to do typed documentation, which is awesome. In general, AI will not affect healthcare or physical therapy. And I say in general, meaning the majority. So basically, I don't think, other than documentation and maybe prediction health and running reports and some things operationally, I do not think AI will change healthcare and specifically physical therapy at all, including on the front end of marketing. Google will still be powerful. Facebook will still be powerful. No one's going to, just like Gary Vee was wrong. I told this to Jimmy when we did it in person months ago. Gary Vee said, this was a prediction he made years ago that was wrong. He said, Alexa is going to take over chat, Google search and Yelp and Apple Maps and everything. And he was wrong. That did not happen. So the way consumers are with what they use and how they find physicians, doctors, specialists, physical therapists, how they even assess them, look at reviews, all that. None of that will change in the next year. They will still be using Google reviews, some Yelp reviews. They'll use maybe some Facebook to get served ads, and then they find out, different healthcare opportunities. Then the actual delivery of the treatment, whether it's the chemotherapy we talked about before, or it's the physical therapy, other than maybe some of the imaging side of things, but in general, physical therapy delivery, the actual treatment will not change. Even as high-tech as Tony Maritato with SoftWave, using that, there will be no change where you take a device, a physical device, and you plug it in, you turn it on, and Tony's treating patients and he's putting out videos, or we're doing manual therapy, or we're doing home visits in New York City and we're going to our patients and clients. Artificial intelligence will not change that at all in the next year. And I know we're trying to keep these predictions condensed for next year, but I'm talking that is not going to change physical therapy delivery in the next 5 years. They will not look any different. Brick and mortar, insurance, cash, out of network, home visits, mobile, sports team, physical therapy, whatever. AI will, in general, 80 to 90% of current physical therapy will not change at all in the coming years, but specifically for the next year.
Jimmy, go ahead.
I like the boldness. Here's the thing. I would be the first person to disagree with that because my prediction was AI was more. My first prediction is, documentation. I'm making the prediction knowing that things like, hey, everything's going to be voice, or these monumental changes will happen. And knowing that they sort of never do, right? I mean, I was in college, in my college apartment when Y2K was about to happen. I remember being like, the future is going to be, this is going to be chaos. And people being like, chill out, man. So progress, I think it comes in leaps and spurts. But even look at the adoption of the internet. It was sort of slow, right? Because I had to deal with connection speeds. If it wasn't able to do what we wanted it to do, we never touched it. That's the only reason I sort of lean toward keeping AI and documentation specifically on the list is it's gotten too damn easy, too damn fast. I had full-on conversations while driving a car just using voice and having conversations while the AI talked back to me. So that's why I think in terms of documentation or in discussing differential diagnosis, if you want to get deep into it, I think it's a tool that we use more. Do I think it will be 90+%? No. I think it'll be more than 50% though in the next 3 to 5 years.
All right. So Dave, you had me, then you completely lost me. Then you had me again. Then you completely lost me again.
All right. Break it down.
First, I don't think Gary Vee was wrong. I mean, I think we talked about this. It's a time frame, issue. Just like Rob Vining with telehealth, he wasn't wrong. He was just way ahead of his time. I do think we're going to hit the point. Like, I'm using ChatGPT voice control way more today than I did 3-4 months ago.
Yeah.
I think we're going to see voice search. We're going to see voice everything. We haven't been able to use it because Siri is a piece of junk. Alexa is a piece of junk. Now that ChatGPT is coming into it with OpenAI, we're going to see it. And I think we're going to see that acceleration just like amplified in physical therapy. I agree with Jimmy. there's nobody who's not going to be using an AI scribe. I disagree with you. Maybe not this coming year, maybe not 2025, but there is no way you're going to tell me that there isn't an AI version of me who's going to handle all of the easy referrals, all of the easy cases. Like, why would I sit in front of another human to talk about like non-surgical shoulder impingement, rotator cuff pain? It's a complete waste of my time, waste of their money, waste of the resources we have available. We see Hinge, we see, there are a couple other ones. These guys already have proof of concept. We also see therapists that are fully online. The next step is just to flip the switch and not be at the other side of the computer, but have AI reproduce them to infinity. I think within the next 3 to 5 years, you're not even going to recognize what therapy is like. I think there will be people who will pay me to touch them, physically touch them, but I don't think 3 to 5 years we're looking at the same profession. I just think the technology is going to accelerate so much faster than we're expecting. Look at maps. Like I never get into a car and go somewhere without turning on Waze or letting the computer tell me where to go, where 5 or 10 years ago, that was completely unheard of.
As soon as I got a Garmin, I didn't even use the Garmin to tell me where to go. I always just wanted to see if I could get there faster than it told me I could. And then eventually now, whenever I go anywhere, it's to tell me where to go.
I mean, it's stuff like, is there an accident? Like, even if I know where I'm going,
stuff you can't possibly see, stuff you can't possibly know outside of your scope. It's like, let it think of it for me.
And humans for healthcare issues are going to go to humans. They're not going to go to a chat bot. They're not going to go to some app. So I'm telling you.
I think they barely go to humans now. I think, yes, there's fleshy bodies that people are going to see, but those fleshy bodies are just space heaters. They're warmers. They keep the seat warm in most clinics today. And I think if you look at the overall profession, the 300 plus thousand therapists that are out there, a lot of them are just, they're taking up space. They're not really doing anything. It's 3 sets of 10 straight leg raise across the board. Doesn't matter what the diagnosis is. So why would I pay a $50 copay to go to that? I still think you see what you do, and the people here, Scott and others, you see what we're doing, but we're such a tiny slice of that pie. I think the vast majority, 50%, 80%, they claim to be burnout. They claim to be sick of what they're doing. They dread going to work every single day. You're going to tell me that they're going to be better than an AI who's got infinite case histories and memory and never forgets anything?
Yes, because part of the, whatever you want to call it, the therapeutic alliance, the therapeutic experience, whatever, part of it is the accountability, which is having them show up, not like the thing that we heard Julia talk about with Sword Health, where some employee does 10 squats a day and checks in, and Julia's like, oh yeah, they did 10 squats a day. I didn't see them do it, but they said they did it. Like, humans need accountability to build a habit, and that includes something as simple as doing 3 sets of 10 straight leg raises. They need the in-person accountability for movement, for loading, for strengthening, for balance drills, depending on if you're 30 years old or you're 90 years old. People need the accountability in person. And yes, you're going to say, oh, that could be digital. Not in the next 365 days.
I agree with you. I agree with you. But that's the person who wants the accountability. That's the person who wants the change. That's the person. I mean, and I'll use my personal life as an example. I came on the episode today being like, man, I ate all this junk and I had a couple of drinks and now my knee is flared up and it hurts when I walk across the room. Like, I knew the price I was going to pay, and I chose to pay that price because I wanted the Moscow Mule and I wanted the apple pie. I just think, just like McDonald's versus Ruth's Chris, there is a larger demographic, a larger population who doesn't want to quit smoking, doesn't want an active lifestyle, doesn't want to exercise. Yeah, it would be nice if my back didn't hurt, but not as nice as lighting up the cigarette and having a cocktail after a hard day of work. And they're totally welcome to make that choice. The population you are referencing is such a tiny sliver of the general public. There's far more. I genuinely, like, we want to talk about that stat everybody cites. I think they say it's 7% of low back pain referrals actually go to physical therapy. That's because 93% don't want physical therapy. Some of them will go because they're forced. They need to fail physical therapy to get the injection, to get the imaging, to get the surgery. But still, we were serving such a tiny sliver of the population that we would love for everybody to want it, but most of them don't. All right, let me hit my AI. So Matt, my AI is going to come into the workflow of things. Originally I was going to talk about AI documentation, but Jimmy stole it. I do think AI will replace, like, why am I still manually admitting a new patient? I know there are platforms that are moving this direction, but the AI can read the incoming facts. The AI can read and process using OCR, optical character recognition, the insurance card, the driver's license. AI could virtually replace my front desk and deliver a more empathetic experience to the incoming consumer. So even if therapists still wanted to be the human delivering therapy, at least let's let AI replace the receptionist, replace the biller, replace the marketing team, replace the stuff that maybe you and I don't want to do. And that's where I think we're going to see huge advances within the next 12 to 18 months. AI should be automating all of those tasks with AI agents.
I saw this wild phone call. This dude essentially just had his cell phone up and he was talking to a plumbing company and he was testing out their AI receptionist. This was not cookie cutter. This guy was calling and he was like, hey, listen, he was talking just like this. Hey, listen, I've got a concern. I saw a thing on the news about these panel boxes before 1974 causing fires. And I just thought, like, I don't know, like maybe I should have somebody come out and like check it. What do you think? And like, it then kicked back immediately. Yes, what you're referring to is before 1974, this brand, yada, yada, could have some issues. Would you like a technician to come out? If so, what day and week? And he was like, how about next Tuesday, anything afternoon? Sounds great. How's one? Like, it was a back and forth real time, unless this guy was fibbing this. And this is for plumbers. So like, we understand business is usually the vertical, the industry that leans into tech. And it's like, I have no problem losing 90% of my investment because I know that 10% is the juice is going to be worth a squeeze. I'm going to get my money back in that 10. What you're seeing there is, or I would say we're in a physical therapy clinic, brick and mortar or concierge, remote, whatever you want to call it. Where's the biggest loss? Is it people never interacting? Like, so the marketing end, or is it the interaction as soon as the person's on the phone and getting booked? Where's the biggest, or not completing plans of care? Where's the biggest loss, if you had to put it?
Well, I think what Tony said is a lot of people don't want it, right? And I actually agree with that. I had to look up obesity rates, and you think of potentially that whole population that would be less inclined for movement or voluntary movement or perspiring or that type of stuff. I mean, it's approximately half our country, right? We have maybe 330 million citizens. So that's like 165 million people. I think the biggest loss is on the front end. So the biggest loss is the people that know about it and don't pursue it, or potentially even further upstream, the people that don't even know that it's an option. They have an achy knee, like Tony. They indulge in a bunch of things. Then they go, they're like, oh, I must need a knee doctor, right? And then it's like imaging, shots, pills, MRI, surgery. I mean, and then they go through the whole medical model and through the ringer that way. What do you think, Tony?
Yeah, I would say while we were just talking about this, the first thing that came to my mind was Jerry Durham. And, he teaches the front desk and he teaches sales and all this stuff. And I'm like, man, he is the perfect guy to create an AI version of a receptionist, a salesperson. I couldn't focus on what Jimmy was saying because I was so stuck on that. I forever have wanted to automate that sales process because I am a terrible salesperson. I want to give everything away for free. I want everybody to come to my clinic for free. I don't want to charge for anything. You know, and even though I know the more I charge, the better the outcome, and I'm not taking advantage of people because these are people that have the resources and have the money. It improves the clinical experience if I charge more, but it's within my own psyche and my own, you know, self-limiting ideas. But anyway, I don't know. Jimmy, say what you were saying again, so I better understand it.
Yeah, my question is usually like we will double down on the place with the biggest friction to see if we can reduce it. So I was saying in a clinic, you know, so saying it's people never getting to PT is outside of sort of our system, if you want to look at it from a scientific perspective. Unless you're saying, hey, could AI juice the marketing to get more people to know, then like, then eventually trust? Understanding it's a funnel, there's going to be less people at each step. Wherever the biggest friction or the biggest loss, I think that's where the biggest investment is. So I'm looking at other industries saying, where are they doubling down on it? I'm looking at that plumbing example going, they understand it's get them booked. My moving company example, no AI there, but I filled out one form and I had like 3 phone calls in 20 minutes because they understood that guy's moving, the first person he picks. I don't think it's as drastic in healthcare because the process is still screwed up. The process still is like, I go where you tell me. I know I have options and everyone's screaming direct access, but do we? Like, I don't think you have direct access until everybody understands, not therapists. Those are table stakes. The populace needs to understand what direct access is. Except I think the mistake we make is we try to educate on direct access. What we should educate on is the end of the process, which is you come in and we get you fixed up before you even ever need to see your doctor.
All right, so this is going to take me into my second prediction. I'm going to jump the line. I think it's the explosion in influence and social media. No surprise. Like, I think that therapists, that's a big endorsement, Jimmy. I think that therapists.
You'll love my third prediction. That keep going.
I think that therapists need to get in front of the consumer. I think that we need to become celebrities. We need to get out there. And so if I continue to build the platforms, TikTok, Instagram, YouTube, I build the community, I can influence that community and really help them in a completely different way, you know, help them in a way that doesn't cost me anything, but gives them access to answers and services. And if you want to talk about the friction point is the consumer has no idea what we're capable of doing, but we're not doing anything at scale that helps them understand what we're doing. And of course, we all do such different things, you know? So I think that, yes, we're going to continue to move away from third-party reimbursement if we want to maintain that kind of small boutique experiential relationship with the client. There's always going to be the big corporates, and we need the big corporates. We need McDonald's. We need Walmart. We need these companies to handle the mass. But for the people here today, we're going to move away. We're going to look at how do I influence the influencers? How do I establish myself so that when somebody wants to come work with me, they know me, they get my jokes, they already have a connection to me, even though I've never spoken to them before in my life. And they're willing to pay whatever price I set because they know that I have the solution for them. Growing that social media relationship.
Go ahead.
So just, I was going to say my second prediction is a kind of similar to that. So go ahead, Jimmy. I'll kick it over.
There was just a great podcast episode on a show that I listened to. It's more about like social psychology. It's called No Stupid Questions. It is a plug. You should go listen to it. And they talked about asymmetrical relationships. Essentially, if Taylor Swift walked by and you were a Swiftie, you'd sort of feel this gigantic affinity. You'd feel like you could walk up and be like, hey, how have you been? Meanwhile, Taylor is off with Travis Kelce and a billion other people, doesn't know who you are. There's a reason for that. Like, we are now in, we've said this before, we're in, and we've always been in it, but now it's been democratized. We're in an attention economy, right? If you have the attention. Mad Men is a great example. Go to the opposite end. When Mad Men was a TV show and they showed, if you had enough money to buy spots on the 3 TV stations and the 4 radio stations in a market, your sales went up gigantically. And it was like, This is where the rich got richer. And if you tried to break into a market to be a disruptor, you couldn't. Well, now we have this. I heard a great line once, right? This was, I won't say who they were because I wasn't supposed to repeat the line, but I'll just take their name out of it. It's as if 20 years ago, we said, I wish there was a tool that we could just have where we could reach anybody we wanted in a certain area or around a specific topic, and we got it. But now we just sort of like bitch about stuff to each other on it in Facebook groups. It's as if you were handed a TheraBand and all you did was launch potatoes. It's like you're using it wrong. You could be using it better to get the results. So I agree wholeheartedly is that we're still not there. I think a lot more people are getting there. I used to walk into organizations and sort of have to convince them why shooting a video or recording a podcast episode or having their own podcast would be of value. Now people come to me and they're like, can you make this simple? And I go, yes, I have a process for that. I've been doing it for 9 years. So I agree.
All right. So my second prediction, the first one I said was AI. You guys went with AI. Second one is more. There will be more people leaving the profession. There will be more therapists opening up their own mobile practices, cash practices. There will be more practice owners that are in-network practice owners that have tighter margins, that are selling to corporates, that are having trouble, having a challenge if they don't change their model, like you are right now, Tony, because you're pointing to yourself if you're listening. There will be more of this activity in the next year, and it all ties back to what, guys? Why is all this happening? It's one thing. What is it?
Declining reimbursement.
Exactly. It's the payment. It's the payment side. So the cash practices like us, we're out of network. We're mostly out of pocket, self-pay, whatever you want to call it. We're completely unaffected by any of this pre-authorization, authorization, no auth, pre-auth, whatever. Like this whole thing will continue to trend. I can pull up little rant things from all these Facebook groups that we're in and about questions like about Medicare billing and the 8-minute rule. And, I got this argument, 20 minutes for therapeutic activities, 5 minutes for Therax. Is this 2 units? Is this 1 unit? It's an argument. And then it's like 20 comments, everyone like disagreeing. And it's insane. We're talking about minutes here. We're talking about literally pennies. Like I'm walking by pennies here. I'm walking by pennies on the ground outside. I don't care about pennies. I'm trying to grow, and you don't grow by scavenging for these little units. And anyway, so it all goes back to the insurance reimbursement. We know it's declining. It is going to be eventually approaching 0 over time. Why not get out of that? I don't understand. Unless you're a practice owner, some of the caveat is some of the practice owners that we've spoken with over the past couple of years are in network, but they have scale, which is why they get eventually bought. They have scale and they're doing great, and they have great margins, and they have a very impressive EBITDA, net income, right? So it's not every practice, but it's the smaller practices that are going to get squeezed out. There's going to be more therapists leaving the profession because they do a rotation there. They're like, oh, this is physical therapy. See ya. Or they do their first job there. Oh, this is physical therapy. This is terrible. I gotta see 20, 30 patients a day. See ya. I'm out of here. Or let me go do what Jimmy McKay did, make my own job or go work somewhere else. There will be more of that in the next year, all across the board.
I'm surprised you said you're not affected. I would say you're positively affected. Like you benefit more than
not negatively affected, so I'm positively affected.
It absolutely works to your advantage. A couple comments that I missed. Dana agreed, add in a deregulatory environment over the next 4 years. We lean in even harder. I've heard that. I don't know that I'm confident that we are in fact going to see deregulation. I would love it. It would be amazing. I think open the doors and let us do what we do best. I just, 49 years old, and I feel like nothing ever changes regardless of the political party in the office. Another one, Corey said, AI won't be revolutionary until it's actually AI. I agree. We're not at that phase yet, but I do think at some point it will make the switch and actually be artificial intelligence. Real
quick, the thing with AI, and you're going to type in your symptoms into some, chat GPT, whatever. No consumer is going to want to pay for it, guys. They're not going to want to pay for, we've already been through this. No one's going to pay for Sword Health and Hinge Health if it's $10 a month, $20 a month, whatever.
But they don't pay.
Right.
Like, that's the thing.
Right. There's some system where like maybe their job pays, but if they work at a place where their job doesn't offer it, then they don't get it. They're not going to benefit from it.
So
they're not even going to use it, and they're not going to pay for it if it's a standalone product. People hardly want to pay for any apps that are really, really valuable. They'll pay for an Uber or a Lyft, obviously, because it's like, I see the trade. I put in my credit card, then a car pulls up, takes me to the airport. Cool, I get it. But no one wants to pay for a differential diagnosis app, even though it could be wildly helpful and popular, and point them to a influencer like Tony Maritato and his free videos and content. But they will not see the value in that.
That goes to my third prediction. I think Dana Strauss would like this, which is maybe we're at the point now where we start to shift to value-based care. You mentioned the Sword and the Hinge, the consumer, the user, if they're actually using it, which we see a lot of people yay or nay on that, are using virtual care, any of these things. You shift the value and you have the employer pay for it because they see the reduction over a large number of people. So can I reduce my costs? If the answer is yes, businesses will skate towards that. Again, healthcare is a business, but we're one of the most risk-averse businesses I've ever seen. It was very jarring to me coming from media and communications. We invested. We waited, right? Because we were business adjacent. Our advertisers were all in business. So we had to know we had to have the next shiny thing that worked. So that worked, right? Like that's where you're like, well, voice works. Does it work well enough to be adopted? So we didn't skate in that direction yet. I do think that's a long play. So value-based care, I think, will start to drive physical therapy. Start in 2025. I think it's still got a long way to go. But I think people like Dana out here banging the drum on value-based care, as she says, providers will take risk and they will get more of the healthcare dollar. This administration will push that forward. What am I going to do? Argue with the woman who reads tea leaves for a living? Like, she knows this. This is her jam. We could give her one topic and she could go 60 minutes without that. So I had her on the podcast. I heard what she was saying. It was very difficult to, find a hole in her logic because this is not my area. But the more I not only listen to what she says and listen to other people talking about the same thing, it feels like value-based care gives several of these groups, payers, businesses, and people, what they want, or whether they use it or not is up to them.
Real quick, Dana, since thank you for watching and engaging and commenting live. Is there anyone doing value-based care? Dana, can you comment here? Or guys, do you know of anyone that's doing this? Like getting paid for outcomes instead of getting paid for like billing units or billing codes and, fee for service and all that? Is it Kaiser Permanente, or is it who's doing it?
I was going to say Kaiser. I don't know the exact model, but they're moving in different directions for sure.
Let's do this. Go on to the next prediction. Dana, check your email. I'll send you the link if you want to come on the live stream, because she's going to give a way better answer in voice.
I only had two, but I now have a third one based on this. You ready?
Go ahead.
Okay. So she said yes, tons. Okay, before I make my prediction, who we got? Kaiser. Okay, it doesn't matter. Last time I checked, healthcare GDP in the United States was about 17%, which is almost 1/5 of every dollar in the entire economy. Are you telling me that model is going to change? Are you telling me that lobbying dollars are going to change? Are you telling me
to?
Oh no, of course we want it to.
I know.
Will it? The prediction is it will never change. It will never change. Not just next year, it'll never change because of the big money in the health systems that own and own hospitals, ACOs, managed care organizations. I know part of the offshoot is the clients that I think Dana's working with, or the clients that I think Jimmy interviewed someone else that was doing like the direct to employer stuff, right? So like you're going direct to employer, and part of that is because of the whole insurance issue, right? Part of the reimbursement issue and all that, and you go right to the employer. 1 out of every $5 in our economy, every time someone swipes a credit card to go get milk, gas, pay rent, whatever transaction in the entire country, 1 out of every $5, almost 1 out of every $5 is healthcare spend. You think that's going to change? I wish I could
Yeah.
wave a magic wand and say, hey, we should be
Well,
value-based care tomorrow.
Here's
It's
what I
never
wish.
going to happen.
I actually wish it was more of a spend. I just wish people got better outcomes because that other statistic you just threw, and I'm just cherry picking the statistic, which is 50% obesity, right? Like, so I'm not just picking on obesity. I'm not saying it's just a movement issue, right? There's a little bit deeper than that. But yes, I wish people got more. Like we look at those charts, right? What our spend on healthcare is in developed nations.
We're the worst.
And where we are, again, I'm making numbers up. Don't quote me, but I think it's top 30. It's like, well, that math doesn't math. We're the biggest spender.
We're terrible.
We're doing it wrong. And then people smarter than me, again, I just listen to smart people and then regurgitate. They'll say, well, it's the bloat, man. I mean, listen to a lot of people who know what they're talking about. They're like,
it's
look
the
at
incentives.
It's the machine.
Yes, it's the incentives because physicians and even physical therapists, but we're, again, Tony, we're a drop in the bucket compared to the billions and billions on overdone surgeries, prescription pills, medications, and all the other procedures, knee scopes, meniscectomies, like the most overdone orthopedic surgery ever. They've done sham research surgeries where they cut everyone. Half the people get the surgery, half the people don't get the meniscectomy of their knee repaired. And then all of a sudden, the 3 month, 6 month outcome reports and range of motion and quality of life and everything is the same. All of it is because of the incentives in the medical system. Everyone, including mostly physicians and surgeons, they get paid for more production of procedures and codes and billable units. If that stays the way it is, and I don't see it changing, then it will continue to be what it is. It's never going to change.
I think we have her on the phone. Dana, can you hear us?
I can hear you.
All right, Dana. I'm predicting value-based care. Let's just say increased by 15% in 2025. That's my bold prediction. This is like asking, a Yankee fan if they like the Yankees' chances. Of course, they're going to be like super pro. This is your jam. Why am I right?
Well, we've been making big progress in the last couple of years, and it's going to pale in comparison to what, for better or worse, depending on how you feel about it, the Trump administration is going to do. Trump's goal, right, was 100% of Medicare and Medicaid beneficiaries in a relationship where their dollars are flowing through downside risk. Downside risk means the provider themselves says, I'm going to bet you, says to the payer, right? I'm going to bet you that I can get better outcomes than the historical outcomes. And if I do get a better outcome for my patients than historical, that I get to reap the financial benefits of that savings, meaning I help drop by giving better care, by doing more proactive care. I give that better care, and then I am in a contractual relationship with the payer so that I achieve those up to 100% in some cases, the savings based on the prior spend for that general population. This is happening right now. We're just going to see it accelerate, potentially through more mandatory value-based care models, where there's been a lot of like hemming and hawing about mandatory models, but you watch how fast things change when mandatory models come into play. Think about the CJR model.
Dave had a good question, and I hope you have good answers. You said in the chat you did. Who's doing this for realsies? This is really nice to talk about, and it's cute, but who's doing this for real money?
Oh, there are absolutely loads of organizations doing it, particularly heavily in primary care. Tony's example about Kaiser, that's a closed system, right? So it's that goes back a long time. But yes, Kaiser's a really good example of kind of the old way of doing it, and not that it's bad. They're doing a great job. But you have large physician practices, advanced primary care practices doing this to great success. Oak Street Health is a great example, right? They provide better care. They reduce hospitalizations, grab onto your seats, okay, by 50%. That's what full risk advanced primary care practice is doing it well. Think about how much money is saved when you reduce hospitalizations for your population by 50%. Do we want to be part of who gets those dollars that are saved by preventing hospitalizations, or do we want to keep being on the end of healthcare that gets the leftovers? And that's the question I keep posing. Do we want to be part of that, or do we not? So yeah, there's lots of examples, right? Like Trinity Healthcare. huge healthcare system, they're heavily in risk in Medicare Advantage risk and the shared savings program and ACO REACH. That's just one example. Mount Sinai, Rush, you name a big health system, they're in it and they're getting more into it. And they're developing their own Medicare Advantage plans and then taking 100% risk within their own Medicare Advantage plans. Just as a couple of examples.
Yeah, where the money is, where the friction is, that's where the innovation is going to be.
Mm-hmm.
Let me ask you this, since most of the people who are going to watch this are small, independent, private providers, like, what's our role? From my perspective, I always look for the least friction possible. So I look at all that and I think that's amazing. That's great for the profession. We need more people like you moving us into that space. But for me today, putting money in my bank account, paying for my kids' education and food, I can't do anything with that kind of model. So what I'm looking at is I'm saying, okay, how can I have a version of this direct to the consumer? Hey, it's January, deductibles are resetting. If you had surgery in December and now you realize you're going to be paying out of pocket because the deductible, I've got a $500 unlimited access to PT services for January, February, or March. How do I find a role or a place in this dynamic?
Yeah, that's a great question, and one that I think about myself quite a bit, trying to reach the, if I, for example, if I, with my little PT gym in my basement, if I were to say in retirement, this is what I'm going to do, how would I get involved in this? I mean, the first simple thing to do is just go on CMS.gov, figure out what practices and health systems in your area are part of the Medicare Shared Savings Program or the ACO REACH model, which will probably go back to direct contracting, and go meet with them directly and ask them if you can begin to partner with them. And you just start very slow. You start with, here's what I can do for you. And you go to them knowing the things that they care about, right? So here's, if you have a patient with low back pain, instead of sending them to ortho, instead of giving them, sending them for an injection or an MRI, send them to me. I will commit to seeing them within 24 hours. We're going to track how we do and how much savings you get out of this because you're managing the total spend. When you see a change as we track this and you see a change in your spend, your total cost of care spend that you're responsible for, then let's talk 6 months from now and how I, as a therapist or a very small practice or whatever, how I can then share in what you're getting, which is a higher percentage of the total healthcare spend dollars. How can, again, showing what I do first, you giving me more referrals to start with, you redirecting patients to me instead of to ortho and imaging, and then we're going to look at the data, the same data you look at. I'm going to show you how much money I save for you, and then we're going to get into a relationship where I share in those dollars because I'm helping you save dollars where you get them back.
Let's get in the game.
So downstream, Dan, I love that. Downstream, it would take some time. It's not going to help Tony and I hit money in our bank account in the next 3 to 5 days or the next month or two. It would take some time to implement this, to talk to these stakeholders, these employers, and all that. Share the data, discuss it. Let's say 6 months, 12 months down the line, we did that. Then what you're kind of saying is it would go from payment per unit like it is right now with being contracted, like you said, to maybe it would be some lump sum, almost like it would be like a larger dollar amount for the whole episode or plan of care. Would that potentially be it, like 12 months down the road?
It's such a good clarification. Thank you. You would be first looking at a different set of volumes, right? Because you're not seeing those patients that Dr. Smith's practice, primary care practice, is sending for imaging and sending to ortho. You're not seeing them. So you're going to have a higher volume of patients just because you've developed that relationship. And there's lots of ways you can show them why, and when you understand what data that they're looking at and care about. So you're going to get that. And then in the back end, there's a number of ways to do it. What generally works really well is something like, we're going to look quarterly at the difference in how we've shifted spend, how we've shifted volumes, and then I'm going to get X percentage higher reimbursement from your risk-based contract, or I'm going to go into a specific, what they call like a subcapitated arrangement. I'm going to go into that arrangement with you so that if I achieve these goals, then you're going to share this X amount of additional reimbursement with me. So it's like you'll get paid and then you'll get an additional reimbursement. And it's easiest to start in Medicare because that's where the highest volumes are, right? And there's already a lot of incentive for providers to get into these relationships. They're very publicly available to see, right? So does that help?
It does. It just, you're super smart. I listened to your episode, I think a week or so ago on Tony's show. I listened to your interview with Jimmy before. Super fascinating stuff. We're mostly self-pay, out of pocket. We do take some out-of-network insurances. What you're describing, I think, is the long-term thing that the country could use and absolutely would benefit from. I don't know if there's enough critical mass of practice owners in the short term that want to do that whole process, do the reporting, track it all. It sounds like you kind of need it to be done, but I love my simplicity of my business model right now. It's like, just like you, we go to get our hair done. We go to, pizza, we pay for pizza. We get the pizza, we give them money. We order an Uber, they charge my credit card, I get in the Uber. Same thing with us with our practice. The transaction is done, it's settled. Unless we're selling like a package, then we're just tracking the package. What you're describing, hopefully I'm wrong. I'm maybe playing devil's advocate. I would love for you all three to push back on me. What you're describing, because we're trying to change the direction of this gigantic boat, it just sounds like so much effort and time. What am I missing?
Money. That'll cause the shift.
I mean, that's it. I mean, right, Jimmy, like the thing is I completely appreciate and sympathize and probably would feel exactly the same way if I was in your position and I was seeing patients in a very small practice or in my home clinic, right? But I think what is hard to appreciate from where we sit as therapists is the dollars that are being, the higher dollars being earned by advanced primary care that's doing this well is really dramatic. Like we're talking about double the reimbursement, and they're doing hard work in primary care to do this. They are having to build out different teams. They're bringing in-house behavioral health. Some are starting to think about physical therapy in-house as well into the team-based practice. So it's kind of like, it is one of these kind of philosophical things. Is our profession's job to support the movement and musculoskeletal health of a population at the earliest stage possible and reap the financial rewards? Is that who we are? Or are the great therapists just going to end up in niche for practices that can, for patients who can pay cash? And I mean, there's physicians doing this too in direct primary care. I would just argue, as a whole, we have to do this, or the profession itself is at an existential threat to its existence in what we went to school for and what we imagine we should be doing to help health of the population, if you think of it that way. I know that's kind of like doesn't really help a lot, but I don't think it's an option. And I think if we don't do it, there's already physicians that are working with therapists to get into these contracts. Do we want to wait for it to be all physicians that are bringing physical therapists along, or do we want to lead in this area ourselves?
The second one, we want to lead. Test, right?
I think I never want to add anything to the academic curriculum. I don't want students to learn about business and all these other things, but I do think the biggest impact here would be how do we influence the younger generation of clinicians that are currently in school, that are going to be coming out of school. These are the messages that they need to understand and be aware of, because they're going to have the biggest impact in this. And this is what's going to drive the profession in the right direction.
Dana, thanks so much. Appreciate you jumping on unexpectedly. Thanks for coming to our radio.
Thank you, Dana.
Yep.
That was fun. Hard to argue with her because she's like, this is what she does. You know what I mean?
So let's think of parting shots. Go ahead, Jimmy. What were you going to say?
I was going to say, agreed, like with Dave and Dana, which is like Dave saying like, but this isn't good for me. Then you won't need it. You've figured out a better way to deliver what someone wants and needs in a way that they're willing to part with money and time. You change who's paying for it when Dana gets involved, because she's saying people who you have given money to dictate how your insurance is or how your care is dispersed. If now you're paying it, now you're saying, well, if someone has knee pain, we say downstream it usually costs $5,000 to get rid of knee pain. I got $2,000. I'll hand it to you right now. You get to keep the rest. That puts us on the same side. Like, that's the only way we win, right? If you can't beat them, join them. It doesn't mean go work for them and become a utilization reviewer. It means get on the same side of the seesaw, value and cost. If we keep beating our chest, I'm involved in the Foundation for Physical Therapy Research. We keep churning out research all day, every day. Look how great we are. We save money. How come you're not? What, do us more? Great. Get on the same side of the fence. Put up or shut up time for our profession. Because if you don't, eventually our reimbursement's going to be zero.
Dave, you're the first one who has to go. Parting shot.
Parting shot. I, as usual, feel very boldly and strongly about my thoughts and opinions. I'll stand by that all day. If anyone wants to, push back, which is totally fine. But we got Jeremy Sutton down in Louisiana that was saying he doesn't see anything changing. He doesn't want to see AI. He wants a relationship with his patients, with the patient-provider relationship. So, I mean, that I don't see AI changing much on the physical therapy treatment delivery side of things. Yes, it will on the documentation side of things. And unfortunately, I think we're going to continue to see more of what I mentioned, more therapists leaving, more therapists being burnt out, more practice owners being squeezed because of the whole payment reimbursement situation declining. And I think the value-based care with Dana's whole idea, the model, like her initiatives, all of that, it's almost, I hope not. I hope it's not too late, but I think it's kind of too late. Like, why didn't this happen, 10, 20 years ago? Why didn't value-based care? Maybe it was around. I don't know. But like, and if it was around, why are we not doing it by now? Right. So like, there's so many of these incentives with whether it's private equity money, it's hospitals, the power with referrals. Someone, buys up all the relationships and they say all the relationships and referrals have to be within the network. They can't refer to me. They can't refer to Tony and all that. All that money is entrenched, and I don't see those incentives changing at all.
My parting shot, the best thing about an episode like this is we take both sides and somebody's going to be right and most of us are going to be wrong. So I hope you guys had an amazing Thanksgiving. Jimmy, how do we close it?
Yeah, I would say, my parting shot is just keep paying attention. I pay attention to what people gripe and bitch about, and then I pay attention to who's solving that, right? Most of the people who are bitching and griping aren't busy solving the problem. So you can't really see them. They're sort of invisible. They're out doing the thing. But I think a lot of the predictions we made are based on what we hear and what we see people talking about. And even though we might sound pessimistic, I think if you scanned all of our text into AI, you'd hear we're deeply optimistic. Maybe we're overly realistic. It's like we understand it's neither going to be Shangri-La or the depths of hell. It's going to be somewhere in the middle. But how you experience it, what your practice, what your career is how well you skate to where the puck is going. Always good to end on a Wayne Gretzky quote, right?
Absolutely.
All right, guys, we'll be back on Thursday with another live stream. We'll see you guys later.